All right. Well, good morning. I'm Fredy Sakr, and thank you so much for the introduction. Thank you guys for just the team, Dr. Bhatt, Dr. Kakar, for the opportunity to speak today, and thank you all for being here. So we're going to talk a little bit today about aortic stenosis, just the disease entity and what it looks like to evaluate it and treat it in today's age. No disclosures for this talk. So just a little bit of an outline. We're going to talk about the disease. We'll talk about how to evaluate it, how to manage it, just what to expect and what's going on in the future, how we're looking at the disease at this point in age. So let's just talk a little bit about the disease first. So this is a heart. Very simple. It's a pump. And the heart pump just wants to work as efficiently as possible. There's two sides to the heart. The right side, which takes blood that's been used by your body, which then wants to pump it to the lungs, get oxygen back into the blood. That blood then comes back to the left side of the heart, and then it gets pumped out to the rest of the body. And for it to do so and to keep blood moving in one direction between the four different chambers in the heart, there are these pop-off valves that open and close to keep the blood going in one direction. And that valve sitting in between the left ventricle, which is the main pumping chambers. When you feel your pulse, you feel that pulse that's being generated by the left ventricle. It pumps it up to the aorta, and between it right there is the aortic valve. Most people, it's a 3-leaflet valve that when you're born, the leaflets are very thin, they're pliable. It opens and closes perfectly with every beat. So what's aortic stenosis? Well, it's a disease of that valve, where the valve, instead of being very thin, soft, and pliable, it starts becoming stiff and restricted. So instead of opening all the way and closing all the way, it starts not opening all the way. And we call that stenosis of the aortic valve, or aortic stenosis. You think about a garden hose, very similar concept. You know, if you have a pump that's pumping forward and that nozzle gets tighter and tighter, as you can expect, blood flow will go faster. It'll go with a bigger pressure difference, the smaller the hole gets. And the problem is, the smaller the hole gets, the more turbulence of flow, and it kind of just propagates the disease entity and makes it worse. And over time, it becomes what we call progressive disease. So it becomes mild, then moderate, then severe, based on how big the opening is when the valve opens or closes. Lots of causes for this. Okay, it's not just one simple cause, and different people, different age groups, different parts of the country or the world have different causes for this. You can have congenital disease that can lead to this. A normal aortic valve should have 3 sinuses, 3 leaflets. But for some people, they're born with just 2 sinuses and 2 leaflets, called a bicuspid valve. Or you may have a different type of bicuspid valve where you have the 3 leaflets, but 2 of them are fused together, and we call that a different type of bicuspid valve. You can also be born with a unicuspid valve, where you only have one basically opening or orifice without the sinuses and without the different type of opening that you normally have. Calcific aortic stenosis, that's the most common that we see in old age in the United States or in the Western world. And that's just simply the atherosclerotic process occurring in that valve. It gets thicker, stiffer with plaque and calcium buildup, and over time it becomes narrower and leads to aortic stenosis. Not so common in the Western world, but just worldwide, rheumatic disease, which is more of a fibrotic. It becomes more of a rubbery, stiff valve, which can also lead people to develop aortic stenosis for that cause. So how do we evaluate people with aortic stenosis? Well, first, the physical exam. Generally, people have a murmur, or they'll know that they've had a murmur, and so that leads to an echocardiogram. The transthoracic echocardiogram is by far, it's bolded, it's a little bit bigger there. That's the main way that we test for aortic stenosis. We also have transesophageal echocardiogram that we can use. Cardiac MRI has become a much more utilized and much more useful test over the last 5 years. Heart catheterization, of course, and then cardiac CT is being utilized much more, and we'll talk about that in a few minutes. So this is a transthoracic echocardiogram. This is looking at the valve, the aortic valve right here. So left atrium, this is the mitral valve. Blood's going this way to the left ventricle and then being pumped out to the aorta, which is over here. And as you can see on this screen here, very thin. You can hardly see the valve. You're looking at it from the side, and it's opening and closing very nicely, or it was. And it's looking down into it. People like to say you're born with a Mercedes-Benz, because it has that Mercedes-Benz sign right there. And you see it opening and closing very nicely. A side profile here now of a valve that's not working the way it should. As you can see here, you can see the valve a lot more clearly. That's lots of calcium built up on it, so it's bright white, and you can see it. And you see it's not opening the way it should be. It's very narrow, and that's a sign of degenerative or aortic valve stenosis due to plaque buildup. So how do we decide if it's severe or not? Well, when we use the echocardiogram, we grade the valve if it's got stenosis as mild, moderate, or severe based on the three general parameters that we've always been using, which is the mean pressure difference. So if there's a more severe narrowing, there's going to be a bigger pressure difference. So we look at the mean gradient there. Back to the hose analogy. If you put your finger over a hose, what happens to the water? It goes faster across and further and narrower. And so we'll measure the velocity on the echocardiogram, and that's one of the parameters. And then lastly, we can use calculations to measure the aortic valve area, how big that orifice is when the valve is opening. And when you're less than 1 centimeter, that's severe aortic stenosis. So one of the things to point out here is the valve guidelines, both the AAC, ACC valve guidelines, as well as the American Society for Echocardiography, both have now incorporated that it's an or statement. So you don't need to have all three of these things. You need to have one of the three of these things. So a mean gradient of greater than 40, a peak velocity of greater than 4, or a valve area of less than 1, any one of those will give you severe aortic stenosis. There are new parameters that we have been using. We'll talk a little bit about them. The dimensionless index, we'll talk about that in a little bit, but it's basically looking at the ratio of the velocity of flow in the left ventricular outflow tract, and then with the ratio with the valve, the flow across the valve itself. The aortic valve area index is a very important number as well. So if you think about it, somebody with a valve area, say, of 1.1 centimeters squared, and a tiny little old lady who's this tall, weighs 40 kilograms, is very different than the same valve in Shaquille O'Neal. Okay, it's just a different, they're different bodies, different amounts of blood flow. So we have to index it, or basically take into account their body surface area, and that's what this number is for. Basically takes the valve area divided by their body surface area and gives us a ratio. And if it's less than 0.6, that's severe as well. So those are easy numbers to remember, but of course, patients never come in a very clear package like that. And so we have to always be trying to figure out what's actually going on. So for example, a patient here, 71 years old, comes in, they've got shortness of breath, they really have just not been feeling well for the last 3 months, and they come in, they got a mean gradient of 30, so a little bit lower than we would expect, peak velocity of 3.2, a little lower than we would want to see, but a valve area of 0.9. So the question now is, does this person have severe aortic stenosis? Now we said that these were or numbers, but we have to make sure that they don't have something called pseudo-aortic stenosis, basically where their heart's just not squeezing very hard, and so this calculation comes out inaccurately. So we have to then question, well, do they really have aortic stenosis or not? And if so, is it truly severe or not? So we have these different entities that are out there. We call them low flow, low gradient aortic stenosis, meaning they have that valve area that's severe, it's 1 centimeter squared, but they don't have that ability to generate the gradients or the velocity that you would expect. That's basically that hose analogy. You put your finger over it, so you got severe aortic stenosis, but you turned the nozzle down so that it's still just dribbling out. So you have to make sure that you truly have severe aortic stenosis, and that if you increase those velocities, it's going to be true. And so we have different ways of evaluating that. So there's the classic low flow, low gradient aortic stenosis, which is basically that the heart squeezing function is not strong. So the ejection fraction is less than 50%. A normal heart should squeeze out about 55 to 60% with every beat. So this is usually a lower one. And I'm pointing these out because the way we can assess them is going to be different. We also have this entity called paradoxical low flow, low gradient aortic stenosis. Basically where the squeezing function, the ejection fraction is over 55%, but when they're squeezing, the ventricle may be too thick, so the actual stroke volume, or how much they're pumping out with every beat, is actually not that much volume. So back to they're not generating the velocity and the gradients that they should be able to. And so with different people, different disease entities, we can evaluate this differently. So for people that have the classic low flow, low gradient aortic stenosis with ejection fractions that are reduced, we can try to augment their hearts. And we can do that, augment meaning we can try to get their heart squeezing a little bit harder, see if we can generate that pressure. And what we'd expect is when we make the heart squeeze harder, the pressure should go up, the velocity should go up, but the valve area should be a fixed obstruction, so it should stay the same when we check on an echocardiogram. So we can give these patients a medication called dobutamine, which is a medication that really just revs up, it's kind of like the adrenaline to the heart, so it makes the heart pump faster and harder, and we should see that their stroke volume or how much blood they're pumping up goes up by 20%, and we should be able to see that the gradients go up, the peak velocities go up, and the valve area stay the same. If they had something called pseudo-aortic stenosis, meaning you're just measuring valve area, these gradients are hard to tell, then what you should see is that the gradients may go up, the velocity may go up, but the area will go up as well. So then they'll tell you, actually their heart's just not squeezing very hard and the valve is okay. That's important to differentiate because sometimes if you can't see, these echo images that we see, you're not always seeing the valve very well. People have different quality imaging just based on their body, so it's not always easy to see, so we rely on these measurements quite importantly. Now, one caveat with this, so one warning is, if you give dobutamine somebody that's got severe coronary artery disease, so they got blockages to the vessels that feed their heart, what's going to happen to that left ventricle? Two things. One, it's not going to augment, okay? So you can give as much dobutamine as you want, that ventricle is just going to sit there because it can't get enough blood flow, so it's not going to do well. And also, it can be quite dangerous because somebody that has severe aortic stenosis and severe coronary artery disease, and now you give them dobutamine, it's like putting them to climb up Stone Mountain, and they're not going to do well. And that could be quite dangerous. So you really want to know their coronary anatomy before you expose them to dobutamine. So then we look at the next step. So another test you can do to kind of figure out do they have true aortic stenosis or not is we can use this number called a dimensionless index, which is actually a number that we use very, very frequently now that we weren't probably using 5-10 years ago. And this is basically just a measure on the echo of the velocity across the left ventricular outflow tract, which is that area of the heart right before it gets to the valve. So the left ventricle squeezes, you got that outflow tract and then the valve. So you measure the velocity there, you measure the velocity right at the valve itself, and you use a ratio. That ratio should be close to 1. But if it's less than 0.25 or 25% of the flow, then you know you have severe aortic stenosis, and you can sometimes bypass having to do more of these testings to prove it or not. And we use it actually quite frequently now. Another test, so we talked about people with low ejection fractions. Now what happens with a paradoxical low flow, low gradient aortic stenosis? They already have a squeezing function that's normal. Okay, so you can give them dobutamine, they're not going to really squeeze more than 60-65%. And so we can't use dobutamine for these people to get a higher gradient, at least not commonly. But what we can do is we can get CAT scans. So for the people that have the calcific type aortic stenosis, we can measure on just a regular CAT scan. It does not have to be EKG gated. You don't have to give medications. You don't have to give dye. All you do is just take a picture of the valve and you measure the calcium score. The same way all these people are doing the calcium score for the coronary arteries, you just do it on the valve. And we have numbers that are quite well delineated and proven on multiple studies and corroborated, and show that if you have a score of greater than 1,300, which is a lot of calcium, when you compare it to the coronaries, just in the valve in women, that's severe aortic stenosis, and you're done with the diagnostic criteria. If you have a score over 2,000 in men, same thing, you're done. You've got the criteria. And these numbers, you'll see different numbers. You'll see 1,100 and 1,800, you'll see 1,600 and 2,200. We've kind of chosen these two numbers as our numbers with pretty good reliability. So echocardiogram, great. CT scan, great. The other way is kind of the old school of doing it, which is a heart catheterization. The nice thing about a heart catheterization is on the echocardiogram, you're measuring velocities, you're trying to measure things in the right plane, but depending on where you're getting it, you may be getting off angle, so you may not be getting perfect pressure gradients on those tests. And so a heart catheterization is actually a very good way of getting the gradients and getting the valve area with very good reliability. And the way we do that is we do a heart cath the way we do a normal heart cath. We cross the valve and we put in a pigtail catheter, We have these pigtail catheters now, and they're called pigtail catheters because they got a little pigtail right there. And you measure the pressure here, you measure the pressure here. It's got two transducers, one at each end, and you can measure the pressure simultaneously at the same time before and after the valve, and you can get a valve gradient there. If you do a right heart cath and get the cardiac output, we have equations that can allow us to get the valve area as well, and you can get direct measurements of their valve gradients and their area, and that can be quite reliable. The nice thing about the heart cath as well is you're going to take a look at the coronary angiogram as well and see if they have any blockages. So if they don't have any blockages, now you feel very safe that you can give them some dobutamine, and you can actually do that in the lab if you'd like. It takes a little bit of time, a little bit of patience from everyone, but you can get direct numbers. You can do the dobutamine, and you can get the diagnosis right there and all the information you need. So why is that important? Why are we doing all of this? We're doing this because it's really important for the patients, both from how they feel, but also for how long they live. So we know this is old data. This is 1968, okay? This is Braunwald data. So we know that once patients have severe aortic stenosis, whether we recognize it or not, but once they have it and they have symptoms, they're not going to do well. Most of them will die within, 50% will die within 2 years. 90% within 5 years, with the symptoms being angina, syncope, or heart failure. So we really got to be asking these questions. Do you feel short of breath? Is it harder to walk up a hill today than it did 6 months ago? Most people will say, I feel fine. That's really because they're just backing off of what they're doing so they don't feel miserable. And so instead of walking up that hill or taking the trash out, they're having someone else do it, or they're doing it in 3 or 4 different steps, and no one wants to admit that they're not doing well. So, usually my patients will come in, usually they're men, they're like, yeah, I feel great. And their wives are like, you don't feel great. It takes you 6 hours, you have to go in and out 6 times to take the trash out or get the mail out. So really having someone there to help you corroborate their symptoms. And when you don't know, one of the greatest tests that we do is we'll put them on a treadmill. Somebody that comes in and says, I have no symptoms, you put them on a treadmill and they get to 2 or 3 mets, and they're saying, I can't go any longer. You've proven your diagnosis. It's very rare to have somebody with true severe aortic stenosis that has truly no symptoms, and it's on us to really tease that out. We know that it's important because we know that the disease is dangerous. It's got a high mortality. People don't do well, but we know also that the treatment for it improves people's outcomes. You replace that valve, I don't care if they're 85 years old or 65 years old, they're going to live longer. And so catching is important, and treating is going to be very important. We'll get there of how to do it. Treating it improves survival, so people live longer, but also they feel better physically, they feel better mentally, and equally important, they're cheaper to take care of. Okay, so an untreated aortic stenosis patient ends up in the in the hospital for heart failure. They don't do well. You have a whole workup you have to do. It actually becomes double the cost to manage them over a 1-year period if you don't treat them, or if you do treat them compared to if you don't treat them. So we treat these valves for survival benefit, for feeling better, and just from an overall cost to healthcare, it's cheaper as well, which is important this day and age. We also know that we need to be really just have our antennas up for these patients, because we're better at catching and treating white men, okay? But minorities and women, for whatever reason, whether it's access to healthcare, whether it's admittance to their symptoms, we just, we don't diagnose them as well, and we don't lead them to treatment as well. And this has been shown in multiple studies. This is just one of them to kind of exemplify that. So you got severe aortic stenosis and you got some symptoms. You got the diagnosis. What's the next step? Well, the next step is you got to replace the valve. These valves are not usually repairable. They have to just be replaced. And there's different ways of doing it. We have both surgery and we have transcatheter options. Excuse me. So for young patients, so this disease usually is a disease of older age. And so, you want a valve that will last 10, 15 years. That's usually good. But for the younger people, there's different options. So these are young people in their 50s, maybe early 60s. These are the people that we think about mechanical aortic valve replacements. That's a surgical procedure that we have to do. And for these people, one of the valves is the on-X valve. The reason why I bring that up is for a mechanical valve, the nice thing about it is that valve will last you 30, 40 years. As long as you live, it'll last, which is great. The negative to it is you have to take Coumadin or warfarin. And so that's a big issue for some people, both from a lifestyle perspective. It affects the greens that you can eat and some of the things that you can do. And you have to get these regular blood tests, although you can do some of them at home now. But it's still a lifestyle change. But at least with the On-X valve, you can keep your INR at 1.5 to 2, which is not that bad compared to other disease entities where you have to keep your blood thinner at 2 to 3. That's based on an INR as a ratio of how thin your blood is compared to a normal person, 1 being just what we're all at. So 1.5 is actually not that bad, and it's a great valve. Surgeons can also do bioprosthetic tissue valves. So pig valves, cow valves, or porcine or bovine. And these valves do great. They generally last about 10 to 15 years with very good outcomes. There's also the Ross procedure. This is a very awesome procedure in the sense that it's for young patients. Sorry, guys. And what it is essentially you take the patient's pulmonic valve. So you cut the pulmonary artery and the pulmonic valve out. You take out the ascending, or the aortic root and the aortic valve out, and basically you sew in that pulmonic valve in the aortic position. And then you take a cadaveric pulmonic valve and put it into this area where the previous pulmonic valve is. And because it's your own natural aortic valve, it works great and it lasts you the whole life. So it's a great procedure. And because the pulmonic valve, you can take that from a cadaver because it's a lower pressure system, so it won't be exposed to the turbulence and the high pressures that you would on the aortic side. And so people do great with this procedure. The only challenge with it is the procedure itself is quite challenging. It's not available in most places in the country, so we really have to find a center to do it. But it's a great option for young patients who don't want a mechanical valve. So if they can find a location that can do this, it's really wonderful. And then there's the TAVR valves. So this is what we do with the transcatheter approach. So this is 2 different valve types. So one is the Edwards valve. This is the Medtronic valve. We use both of these valves. These are about 90% of the market share in the United States. There's other valves out there, and you'll see them being used in different parts of the world. But for the most part, this is what we use. This one here, made out of cobalt chromium metal. That's the framework that it's built upon. It's got a skirt on the bottom here that allows a nice seal so you don't get any blood flow around the valve. And then a bovine or cow tissue sewn on the inside. And the way we use this is we basically crimp it on a catheter. And I'll show you guys a schematic of this. But basically you do it all from an artery in the leg. And you just take that valve up, you go through the old valve, you expand it, and you got a fully functioning valve right there. So we call that a balloon expandable valve, and it opens up with a balloon. This valve here is a Medtronic valve. It's a nickel titanium valve. So basically the metal is made to want to go back to its original form. So when you crimp it on and you basically release it, it flowers open. And it's got a skirt as well, and it's got a porcine valve on the inside of it. And it's got these little cutouts here, which is a newer thing to allow you to get back into the coronary artery. So, you're not dealing with that and cursing the person that put a TAVR in for you. So this is a little schematic here of the balloon expandable valve. And you see here, we went in from the leg. You're taking this long sheath or a catheter up through the leg and the valve there. You're pulling the balloon into the valve, and all this stuff is over a wire that you have already across the aortic valve. This video is a little bit of a test of my patience because I can't figure out how to make it go faster, and you just kind of go through. So they're coming around, put a little bend on that catheter, and then you go through the old valve very carefully and slowly. And there you go. Then once you get it positioned, you unsheath the catheter to expose the balloon a little bit better, position it right where you want it to. And we have a temporary pacemaker put in the leg as well, into the heart. And then here, we basically pace the heart at about 180 beats per minute right there, so that's why it's quivering. Then you expand the balloon, you're crushing the old valve to the side, and you got a fully functioning valve immediately. You deflate the balloon, take the catheters out of the leg. We usually have a couple of stitches in the groin, the femoral artery. So these patients are sitting up within a couple of hours. Most of them go home the next day. So really just a wonderful technology. This is a couple examples of us doing it in our hospital. So you see the expandable, the balloon expanding there. This one here, just kind of releasing it, the last bits of it right there. So it's a taller frame. And both are great valves just for different, anatomies and just basically what the valve size that the patient's born with, how much calcium they have, which helps us decide which valve we would use. So in 2017, we had the updated guidelines for when to choose surgery or TAVR. Very simple, just based on high, intermediate, low prohibitive risks. And that was how we decided if we need to do a TAVR or surgery. But that was too simplistic. And in 2020, we had an update to the guidelines. And as you can see here, much more complex. Now, I'm not saying, you don't have to take a picture and memorize all this stuff, but just to show how much more complex of a decision point it became. Now we're looking at age, we're looking at their tolerance to blood thinners, we're looking at their life expectancy, we're looking at their surgical mortality. And so there's a lot more things to look at. So the question is, what happened? What led to this? And really, it's the studies that came out. So when TAVR first came out in the early 2010s range, it was first studied in people who were prohibitive risks. These are people that are too high risk for surgery, the 90-year-olds. And it was basically TAVR versus medications. And TAVR, amazingly, was a lot better than nothing for these patients, which actually was an impressive thing because it showed that a 90-year-old, a prohibitive risk person, can get a procedure safely that can improve their longevity, their quality of life. And so all the cardiologists were very happy about this, and so they tested in high-risk people. These are people that had a surgical mortality of over 8%. And then they looked at people who were intermediate risk. So these are people who had surgical mortality between 3 and 8%. And then finally in 2017-18, they did the low-risk trial, both for the Edwards and the Medtronic valve. And as you can see here, just really phenomenal results with mortalities that really just parallel together. There's actually even a moment where people thought that may be superior compared to surgery. But for the most part, it's been pretty good. And this is 5-year data out so far that has shown that there's been parallel in their in how well people are doing, both from a survival perspective, a heart failure perspective, and quality of life. So cardiologists love doing procedures. So by 2019, literally a year after that data came out, there were more TAVRs being done than surgeries in the world. And so it wasn't that the surgical volume, which is this black line, was necessarily going down very much. It's just that cardiologists found a lot of people to do TAVRs on. And so, that was exciting for cardiologists. But it kind of went a lot, meaning that every patient was getting TAVR. You tell somebody they have severe aortic stenosis, whether they're older or younger, everyone wants a TAVR. Because they can go home, they can go back to work quicker. And so we were doing more TAVRs and surgeries at every age group. So people less than 65 were getting more TAVRs. People in the 65 to 80-year-old range were getting more TAVRs, which is the orange line. And then obviously 80-year-olds were getting almost exclusively TAVRs. And the question there is, well, is this the right thing or the wrong thing to be doing? We love doing TAVRs and it feels like it's a quick, easy fix, but is that the right thing long term? And that brings us to now the future direction. And what we're really trying to reassess, it's like everyone went full force, TAVR everything you see, to now let's think about it a little bit more. So we're always thinking now, the big buzzword now in the TAVR and the AVR world is lifetime management. Okay, so we're not just thinking about how do you get a valve into this person safely. We're thinking now, what's going to be the best thing for this person for the rest of their life? Is surgery the better option today versus TAVR in the future? Which TAVR do you use if you are going to use a TAVR? We got these different options, different platforms with different pros and cons. What's the better option? If they're going to get surgery, what surgery do they get? Do they get a Ross procedure? Do they get a mechanical valve? Do they get a bioprosthetic valve? Do they need a root enlargement so you can fit a bigger valve to hopefully last longer? The valve after that, we need to think about, can we fit in multiple valves in these patients safely? And if so, what's going to be the game plan moving forward? And so the mainstay for how we decide this is going to be the CAT scan. So on every patient that gets evaluated for an aortic valve replacement, we get the CT TAVR protocol, which is essentially a CT scan that's gated and timed to look from the femoral down into the femorals up to the neck. And what we're looking for there is a handful of things. One, we want to make sure we can get into these vessels safely. We need about 5.5 millimeters to get up there. And so some people have really bad disease. If they got bad disease in the valve, they probably have bad disease in their legs. So we got to assess how much disease do they have. Can we go in safely from the femoral arteries? Do we need to go up from the neck and going from the carotid or go from the subclavian? We have this procedure called a transcatheter. We can go in from the vein, poke in from the vein, and then poke across into the aorta, do the valve, and then come out and put a little plug in there. So really just cool technologies we can do, but we need to know what we're dealing with. It's basically the roadmap before we go in. We look at the valve area, we look at the LVOT area, we look at the sinus of Valsalva. We're basically looking at all that anatomy and trying to make sure that we can get the valve in safely. One of the most important things we have to look at is the coronary arteries. Those come off very close to the valve. Valve's right around here, the coronary artery is here. So if you crush the old valve to the side and you occlude the coronary artery, you got some big problems. So there's different ways around that. We can lacerate those leaflets with a wire so that they flay open to the side instead of doing other stuff. So I'm sharing all this stuff because not that you need to be worried about this stuff, but there's a lot to think about every time you do any sort of aortic valve replacement on these patients. And so we're processing through all of that. So this is very good, for deciding on which valve to use for the first valve. But we talked about, well, we need to be thinking about lifetime management. And so what does it look like to put a second valve in these people? And so there's new technologies coming out. One of them is this DASI program that's out today. It's an AI program. And so what it does is it helps model, when you put in the valve. So for the first valve, we look at the different sizes, we look at the calcium, but it allows us to look at different other numbers as well to look at, what's the stretch index on the aorta? Is there a risk for rupture? What's the more intricate numbers to decide if there's a risk for coronary obstruction or not. And then a really cool thing that we can do is we can actually model what a second valve, so maybe an Edwards instead of a core valve, or Medtronic valve, or other way around, or one inside the surgical valve. So we can model for every patient what the current valve is, where to land it if we think about another valve, a couple millimeters lower or higher, and then we can plan out what the second valve is going to look like as well. So this is a newer technology that we have, and actually it's only available in about 10 to 15% of hospitals nationwide, and we've been fortunate enough to already have it in the last couple of months, so it's kind of a cool thing to use. So, one of the other questions that comes up now is, well, what about those patients that don't have symptoms, okay? We know that patients that have severe aortic stenosis and symptoms that we should be treating them. But if you read Braunwald Cardiology, it'll say on there in the last couple sentences on aortic stenosis that the biggest risk to a patient who has severe aortic stenosis and no symptoms is a cardiac surgeon that wants to cut on them. And he says that because back in 1968, the in-hospital mortality on a patient in their 60s was 16%, okay? And so that was a very true statement at the time. But now, regardless of if you are high risk, medium risk, low risk, your 30-day or 1-year mortality is significantly lower than it was 60 years ago. And so that question now comes up, well, do we need to wait till symptoms or not? And there's a trial that came out a few months ago that basically looked at this. And it showed that if you do treat somebody with severe aortic stenosis without symptoms, that one, you weren't causing any harm, which is an important thing to rule out. But two, that you may actually have some benefit. It was not a mortality benefit. That being said, it was looking out to 5 years. But it was driven predominantly by hospitalizations before their valve. So it's really brought up the conversation of, do we need to wait for symptoms or not? We talked about how cardiologists love doing procedures, and so if severe aortic stenosis is bad, is moderate aortic stenosis bad too? So there are current trials looking now at moderate aortic stenosis, both in the Edwards industry and Medtronic. But one that's really interesting is, for patients that have heart failure, we know that we have to really augment their afterload. And so for patients that have moderate aortic stenosis and heart failure, does improving the aortic stenosis help that or not? And that's a current trial that's being enrolled in right now as well. Procedures, fixing the valve is kind of the late stage of aortic stenosis. Well, what about if we catch them a little bit earlier, mild or moderate aortic stenosis? Can we try to treat them with medications to slow down the progress? We know that statins, that's usually what we use, but there's not great data for that. But there is a trial right now that we're actually part of enrolling in, which is called the EVOID AS trial. It's evogliptin, which is a diabetes medication, DPP-4, that showed in mice that it slows down the progression of the calcification process of these patients' valves. And so we're currently enrolling now to see if that is true for humans as well. So patients that have mild to moderate or moderate aortic stenosis, we put them on this medication and then we follow their CAT scans and their echoes over 3 years to see is that slowing down the process or not. So really cool thing to study. So as you can see, aortic stenosis, both the evaluation, the management, and the post-management is very complex, and it's something that just needs a team. And obviously in Michigan, we had to give a little shout out there, but the team is what Bosch and Beckler would always say, and it's truly the case for management of, I think, a lot of heart disease in general, but certainly for aortic stenosis. And so who is part of the team? Well, you know, every medical provider, you know, we're all first contacts to these patients, our primary care doctors especially. You know, they hear the murmurs, get the echoes, they're making the first diagnosis, which is incredibly important. Our local cardiologists, you know, these are the people that are really teasing out, you know, this truly aortic stenosis, do they have symptoms or not? And that's just incredibly important to help get these patients in and be seen. And we talked about that there are a lot of patients that are not being, you know, getting them from the disease diagnosis to treatment is just an incredibly important thing. And so we need our cardiologists to really be on top of that. And thankfully in our community, we really are blessed with great cardiologists. And when we get to the treatment stage, you know, it's, you know, when you refer to a valve replacement clinic, you're not referring to Fredy Sakr or Dan Winston as an individual. You're getting a whole team evaluation. You know, it's the structural cardiologist, it's the cardiac surgeons, it's our cardiac imagers. We have a specialty now of cardiac imaging that just looks at all imaging components, the MRIs, the CAT scans, and just working together on deciding what's going to be the best valve for these patients is incredibly important. Obviously, our cardiac anesthesiologists are wonderful, and we have structural coordinators that help these patients navigate through this process, which can be quite, you know, complex. They have a lot of tests and a lot of people to see. And then, of course, after they get their valve treatment, it's back to the cardiologist and back to the primary care doctors. It's the follow-up. You know, these valves don't last forever. And so watching them and making sure that they're doing okay and making sure the valve's doing okay is really, really critical part for their management long-term. So when to call, honestly, once a patient has a murmur, they got to get an echo, they got to see a cardiologist, because the options and the management really is just, it's a great time to be alive in medicine. There's so much available for patients today. And I think getting them to see these physicians as soon as possible is the best way. And that is all. I could take any questions.